Hello, and thank you for joining us today. Adoptive cell therapy with genetically modified T cells has generated tremendous excitement, showing rapid and durable responses in patients who previously had very dismal outcomes and limited treatment options. In this ONC Live peer exchange discussion, I am joined by a panel of experts in the field of chimeric antigen T cell therapy. Together, we will look at the newest data, including data from ASH 2018 annual meeting, to shed light on how these therapies are evolving and how they will shape the treatment landscape during the next several years as we expand the availability to more patients. I am Dr. David Maloney, Professor of Medicine at the University of Washington and Medical Director of the Bezos Family Immunotherapy Clinic at the Seattle Cancer Care Alliance and at the Fred Hutchinson Cancer Research Center in Seattle, Washington. Participating today on our distinguished panel are Dr. Nilanjan Ghosh, who is Chief of the Lymphoma Division at the Department of Hematologic Oncology and Blood Disorders, and Associate Director of the Clinical Trials at the Levine Cancer Institute, Atrium Health in Charlotte, North Carolina. Also Dr. Leo Gordon, Abby and John Friend, Professor of Cancer Research and Professor of Medicine at the Feinberg School of Medicine and the Robert H. Lurie Comprehensive Cancer Center at Northwestern University in Chicago, Illinois. Dr. Matthew Lunning, Associate Professor in the Division of Oncology and Hematology at the University of Nebraska Medical Center in Omaha, Nebraska, and Dr. Michael Pulsipher, Section Head of the Blood and Marrow Transplantation and Professor of Pediatrics at the Keck School of Medicine of the University of Southern California and Children's Hospital, Los Angeles, California. Thank you so much for joining us. Let's begin. So first of all, I think we should provide some historic perspective on the outcomes of these patients that are traditionally now eligible for transplant and potentially now eligible for these newer treatments. Dr. Ghosh.
So with the frontline treatment in diffuse large B-cell lymphoma, number of patients, maybe 60 to 70% of patients could expect long-term remission with frontline chemoimmunotherapy. However, patients who are primary refractory or patients who relapse after that end up getting salvage therapies. For those patients who are chemosensitive to those salvage therapies and eligible for autologous transplant, that is the standard of cure. Unfortunately, many patients relapse after transplant, or many patients actually never make it to transplant because they are chemo-refractory. And that is a huge unmet need, and that is the population where retrospective studies have shown that the overall survival is very, very low, as low as 6 to 7 months, and new treatments are indicated in that.
So what data do we have about the outcomes of salvage therapies for these populations?
So the Scholar 1 data, which was published by Michael Crump and colleagues, showed that the CR rate was less than 10%, and the overall survival was in the tune of 6 to 7 months. It turns out that the patients who continue to be refractory have worse outcomes than the patients who relapse, and that's sort of defined as a benchmark to compare with subsequent therapies.
So our typical standard would be to try to give these patients who have primary refractory disease or first relapse salvage chemotherapy, and if we can get them into a good remission and they're transplant eligible candidates, would be to go on to a transplant.
Yeah, I think I'd agree with what's been said. I think there's a fine point there that we probably should focus on a little bit, and that is those patients who are chemotherapy sensitive. You can define that in a number of different ways. There are patients who are chemotherapy sensitive who may have a 50% or 51% response. And I think there are some investigators that might take those patients to transplant, but there are some, at our institution, we like to see patients either in complete remission or near complete remission before moving on to transplant. There's probably some variability around the country in who goes on to transplant.
I agree. I think the most difficult part of my clinic is when you're seeing a patient post-salvage therapy and they're getting their PET scan and you have a Deauville 4. And that Deauville 4 kind of can show, to your point, good chemosensitivity, and there might be one residual site of disease that you could say, okay, they've had a significant debulking, but they're still a Deauville 4. Could I take them to a transplant and consider post-transplant radiation in that patient population, and still attempt the curative intent, versus a different Deauville-4 where you haven't seen much size reduction, and the delta SUV or the change in the SUV is really not that impressive. You really have to, I think that there's two different populations. But I agree with you, those PET CRs, I think standard of care is still to try to take them to transplant.
Right, and I think one of the questions about the data from the SCHOLAR-1 study is it's not hard to tell exactly how many of those patients actually were in remission going into their transplant. Some might have been, and some actually might not have been. So that has to weigh in a little bit on interpretation of the data. But I'd agree with what's been said. The results of the SCHOLAR-1 study were eye-opening in many ways, and really provided a basis or a rationale for use of newer treatments, and that's where the whole idea of CARs come in.
I agree. It basically signaled the alarm to the oncology community that this is a population that needs novel therapies, and CAR T-cell, I think, is providing an avenue, at least for the research and now with approvals, to really see if we can increase the long-term disease-free survival in this population. Which
Yeah, I think these are excellent points, but I also think it's important to remember that the advent of rituximab combinations has improved the outcome, but it's also worsened the risk when people relapse. So our outcomes with transplant are not as good
And
as they
especially
used to
the
be.
early relapse patients,
Right, people
within
who
1
relapse.
year of their frontline chemoimmunotherapy, the outcomes appear to be worse than the patients who have relapsed late.